start with our instruction course. This is the instruction course with a difference. And we'll be talking about how to document various specialty cases with the use of simple colored diagrams. So each one is, one of the speakers is an expert in their field with a lot of teaching experience and work in institutions. I introduce Dr. Viji Rangarajan, who's in charge of orbit oculoplasty from Aravind, Coimbatore. She will share her experience on all the cases and how to document orbit and oculoplasty cases.
Giving some details of how to document a case when with a patient, when a patient comes with some orbit or oculoplasty problem. Okay. So whenever a patient comes, the examination should be done always in a methodological way, and it has to be always documented. So the documentation in a oculoplasty case should always start from the eyebrow. So the examination should commence from the eyebrow and then move downwards. So with the patient's eyes open, always look for whether the patient has got any ptosis, lid retraction, entropion, ectropion, telecanthus, or any lateral canthal malposition. Okay. So there are different malpositions in the eyelid, like uriblepharon, which is lengthening of the horizontal palpebral fissure. I look for any lower lid retraction, look for blepharophimosis here. You can see this patient has got an ectropion in the right lower lid. Look for dermatochalasis, entropion, or any ptosis, and any brow ptosis here. The patient has got lag of thalamus, but he has a brow ptosis and also lag of thalamus. So all these should be documented when the patient comes for, and all this should be seen with the patient's eyes open. So coming to entropion documentation, entropion is inversion of the eyelid. So first, when you see a patient with entropion, always invert the lid margin to see if there's any scarring of the tarsus. And ask the patient to close the lid forcefully, and you can see there is an overriding of the preseptal over the pretarsal orbicularis. And do a different test to document entropion is eyelid distraction test, eyelid snapback test, medial canthal tendon laxity, lateral tendon laxity, scarring of the posterior lamella, and look for the site and severity of the scarring. So how will you do the lid distraction test? It's otherwise called the pinch test. You hold the lid here in the middle of the lid and pinch that lid and pull it forward. If it moves more than 6 millimeters from the ocular surface, that means the lower lid is lax. Okay? So the snapback test is, this test, it signifies vertical lid instability, where you pull the lower lid downwards towards the inferior orbital limb and then just leave it and see the speed with which it snaps back. So if it takes more than 3 seconds, that means the lid is very lax. And other laxities are lateral canthal tendon laxity, where you hold the lid like this and pull the lid laterally, and if the punctum moves more than 3 millimeters, then the lid is very lax. The normal resting position of the punctum is just lateral to the plica seminolaris. And and then the medial canthal tendon laxity, and also for the lateral canthal tendon laxity. So the grading of the entropion is grade 1, where only the posterior lid border is enrolled, grade 2, where there is interning of the intermarginal strip, and grade 3 is where the whole lid, including the anterior border, is enrolled. So why it is important to document this is, when you have a grade 3, you can see most of the time the patient can have conjunctival congestion and also corneal problem. So coming to ectropion documentation, ectropion is again eversion of the lid, and the same tests are done like eyelid distraction test, snapback, and also you look for any scarring of the anterior lamella, which means it's a cicatricial ectropion. Look for facial any asymmetry. If there is any history of trauma, they can have facial asymmetry. Look for any follicular conjunctivitis, and also do a punctal examination, because chronic ectropion can lead to punctal scarring and also keratinization. Again, both these examinations I have already told. And next is coming to grading of the ectropion. Grade 1 is where only the punctum is everted, and grade 2 where the whole lid margin is everted and only the palpable conjunctiva is visible, whereas grade 3 the whole fornix becomes visible like this. And next to coming to ptosis documentation. So here appropriate history taking is very important. Always look for any external causes and first rule out pseudotosis. Whenever a patient comes, rule out pseudotosis and look for other examinations of ptosis per se, which I will be coming in detail now, telling in detail. So first is the palpable fissure height examination. So this is the distance between the central upper lid margin and the lower lid with the patient looking straight ahead. Okay. So and the marginal, this will be around about 9 to 10 millimeters. And margin reflex distance is from the central, from the corneal reflex to the central upper lid margin, and MRD2 is from the corneal reflex to the central lower lid margin. And this is normally is 4 to 4.5 in Indian patients. And based on palpable fissure height and the MRD, ptosis can be classified as mild, which is about 2 millimeters, moderate will be 3 millimeters, and severe ptosis will be about 4 millimeters or more. So levator function, you can, there's a Beard's classification where the levator function normal is more than 15 or 18 millimeters, 15 to 18, good is 12 to 14, fair is 5 to 11, and poor is less than 4. So how will you examine or how will you do a levator function examination? This is called as Burke's method. First ask the patient to look down, negate the frontalis action by placing a finger on the forehead, and then ask the patient to look in extreme up gaze. So then the millimeter of excursion from the 0 to the number of millimeters the lid that is goes up is the amount of levator action. So normally in males it's 6 to 8 and in females it's 8 to 12. So this is how we should document any ptosis case. Look for MRD, levator function, palpable fissure height. Lid crease is where the distance between the lid margin to the lid crease with the patient looking down. Look for any lag of thalamus, because the lag of thalamus can worsen after ptosis surgery. Lid position on down gaze, especially in children, when in down gaze they can have a lid lag. Document all that whether the child has got a lid lag or not. Jaw winking, and this is an aberrant regeneration between the trigeminal nerve and the third nerve. Bells again is if the bells is poor, it's a relative contraindication for any ptosis surgery. Look for any Herring's law, and also ask the patient to look up for 30 seconds and see if there is any the lid droops slowly. So that means there is some like ocular myasthenia or not, and also look for fatigue. So coming to proptosis documentation, this is the way we have to measure. Most commonly in how we measure is by doing the Hertels. Hertels is the most common method used for documenting proptosis. And in case you don't have, also you can take a simple plastic ruler, keep it at the lateral orbital rim at the level of the lateral canthus, and look where the orbital apex, the corneal apex is seen on the scale. So, and in any cases of proptosis, look for other features like extraocular movements in all primary gaze, abduction, adduction, and elevation and depression. And also one very simple sign to document proptosis is doing a bird's eye view, where you stand behind the patient, look tangentially over the patient's forehead. You can see the corneal apex of the proptos eye, which will be seen first. And worm's eye view is ask the patient to tilt the head back and you see from downwards. Again, this is a very simple test to document whether the patient has got a proptosis or a enophthalmus. And this is for looking for the horizontal or vertical displacement. So you can see the horizontal displacement is from the center of the nasal bridge to the nasal limbus, and vertical displacement is from a line drawn horizontally from the center of the normal eye to the corneal reflex. So coming to evaluation, look for all the different task histories like the 6 P's and that is 4 P's of history and 4 P's of physical examination are very important, like pain, progression and past medical history, pain, and can give a sign whether it's an acute problem or a chronic problem, and also any past medical history for thyroid or whether he's taking any systemic medication or any other treatment like prior irradiation should be noted. And also 4 pieces of physical examination will be the proptosis documentation, palpation of the orbital rims, and also pulsation, which signifies whether it's a vascular pathology or not, and also look for any periocular changes like lid retraction or whether there are any scarring of the lid or whether there's any Salmon patch. So when you get a case of, this is how you have to document in your case sheet, like do a Hertel's examination, globe displacement, which I already said, both horizontal and vertical, palpation, retropulsion, Brui, pulsation, Valsalva maneuver, which can be done, that is a forced expiration against resistance, or you can by doing a compression of the jugulars, and or also ask the patient to bend down. So you can see there's an increase in proptosis. And forced duction test is done whenever there's history of trauma, especially when the X-ray shows any fracture or a CT also shows any fracture. Next, coming to the lacrimal system, you can rule out any lid or lash, first rule out lid, lash or corneal problems, any mucopurulent discharge, Schimmer's test like Schimmer's test 1 and 2, and also do a slit lamp examination to rule out, to see for tear meniscus height and punctal position. And other vital signs like dye disappearance test, palpation of the canaliculi to rule out whether there's a soft stop or hard stop, and lacrimal irrigation. So small diagrammatic representation would be like if there is a ectropion, you can draw it like this, and if there is a lacrimal mucocele, you can draw the medial ectropion with a mucocele. And these are the findings on syringing. This is when you syringe through, this is a syringing through inferior canaliculus, and when it is patent, you can draw an arrow like this. And this is when there is a partial block, you can draw a block, dotted arrows. If complete block, you can draw a solid arrow. So this is how you can document lacrimal system drainage, any problem. And coming to lid mass, the site of the mass, the size, the color, the margin, any ulceration, area of pigmentation, bleeding, telangiectasia, palpation, and you have to also palpate the regional lymph nodes and lid margin architecture for any loss of lashes or punctal involvement is very important. So some of the benign, common benign lesions like chalazion, these are the hemangioma and nevus. Oh, sorry. And some of the common malignant tumors are like basal cell carcinoma, squamous cell, and malignant melanoma. And what is the importance of documenting lid mass is mainly you want to rule out whether there's any invasion of deeper structures and to rule out malignancy. And for lid injury, again, this is very important, especially for medico-legal purposes. So you take a detailed history and always rule out any neurological or cardiovascular cardiopulmonary problems, examine periocular structures, lid, and also extraocular movements. And always palpate the orbital margins and any swelling and look for any foreign bodies. And anterior posterior segment evaluation is a very important, slit lamp, and always look for relative afferent pupillary defect and also forced duction test. And again, look for any all vital structure examination is important, especially the lid margin, the levator function, the canthi, and the canaliculus. And a simple diagrammatic representation like this is very useful, especially for medico-legal purpose. And next, coming to socket evaluation, look for the socket, whether the conjunctiva is healthy or whether there are any whether there are any shallowing of the fornices. This can be done by using a caliper or using a scale. And this is how you document a socket by implant position, any the sulcus deformity, in ophthalmos, lid position, fornix depth, and the prosthesis fitting. And these are the facial dystonia. How will you document this? By most commonly we see hemifacial spasm and benign essential blepharospasm. You can mark the findings on the pretarsal and the periorbicular orbicularis muscle, and you can gauge how much of botulinum toxin to be given in these cases. And you can also have a chart like this, so that and this is one of my last slides. The photographic for photographic documentation, always obtain a consent from the patient, and pre-op and post-op appearances are very important, especially before doing any surgery. Take photograph of one eye, both eyes, with both eyes open and closed, and in all cases, and photography of the imaging films also is extremely important. Thank you.
Thank you, Dr. Viji.